Hi everyone, how are you? You're about to start. It's already 8 p.m. Yeah. Okay. Good evening, everyone. Welcome to our webinar tonight, COVID-19, where are we now? So I hope you guys are ready to have 2 hours of fruitful discussions. Thank you for your time to join us tonight. I'm sure this will be a really great discussion amongst all of us. I am Nabila binti Osman, and my MBA course mate today, Adam, will be your moderator tonight. Okay, as we all know, tonight we'll be having 4 great speakers. I will introduce to all of you to the speakers tonight. However, let me remind you on a few things. Okay, next. Okay, first, I appreciate if you are a manager or a dentist or a doctor of private dental clinic, kindly fill up the questionnaire that we have emailed to you on your registration confirmation. The QR code is available on your screen right now, or I'll also share it after this. I'm currently doing my study on readiness to adopt dental tourism. Therefore, your input will be really beneficial. So I really need your help to fill up the questionnaire. We will also email you the e-certificate and also the CPD point after the webinar. So don't worry about that. And reminder for those who are going to redeem the 1 CPD point for this webinar, make sure you need to stay until the end of this webinar, and we'll be giving you the QR code, and then you need to fill up the details from there, and the attendance will be recorded via Zoom. And good news for tonight, we have 10 lucky draw. So each winner will win RM20 ringgit of Grab voucher. So do stay tuned until the end of this webinar. When your name is appear on the screen, please respond in the chat box so that we know you are here. And last but not least, as we move along throughout this discussion tonight, please feel free to put any of your questions at the Q&A box. So we will answer during the Q&A session later, yeah? So now let me introduce you to the speaker. Next. Okay, so hold on. So this is the QR code. I give you 10 seconds to scan this QR code and fill up the questionnaire from this QR code. So your input is really beneficial, and based on this, we'll be giving you the e-certificate later. And you have a chance to win 100 cash voucher if you are the lucky winner, but we will mention this after the webinar for those who fill out this questionnaire. Okay, I hope all of you have scanned this. Okay, we move on to introduce to the speaker. Our first speaker is Prof. Datuk Dr. Lokman Hakim. He is the Professor of Public Health Department, IRD in IMU. His topic tonight will be on current SOP, do they work? So you can ask questions regarding this. Our second speaker is Associate Professor Dr. Nur Adina binti Baharudin from Department of Restorative Dentistry, Faculty of Dentistry, UM. She is a member of Academy Professor Malaysia. Her topic tonight will be challenges in dental fraternity. Our third speaker is Dr. Wan Nurmila Muhammad. She is a senior lecturer, Faculty of Business and Management, UITM. She will be discussing on health tourism and prospect and future. And last but not least, our fourth speaker is Professor Mustafa bin Muhammad Ali. He is a clinical pharmacologist and toxicologist, former professor and deputy dean of Faculty of Medicine UM, fellow Malaysian Academy of Sciences, And his topic for tonight will be on enhanced immunity for COVID-19. Therefore, without further ado, I will pass the stage to Adam to have his talk with our speaker tonight. Adam,
Thanks,
to you.
Bella. All right, good evening, everyone. So I think without further ado, I think we go straight to the main agendas of tonight. And first of all, thank you everyone again for joining us tonight. So our session will be with the speakers. Every speaker, we have 15 minutes to have the talk. Then after each session, we'll continue to the next speaker. Towards the end of the sessions, we're gonna have 30 minutes of Q&A sessions. So if you have any questions, either you can post your question in the chat box in the Q&A column in the Zoom functions, or you can just type it in so that towards the end of the session, after all speakers have given their talk, I will read out your question for all the speakers. So without further ado, I would like to invite Professor Datuk Dr. Loman Hakim, the Professor of Public Health Department from IRDI IMU, to talk about the current SOPs and do they work. So please give a warm virtual welcome to Professor Datuk Dr. Lokman. Prof.
Thank you very much, Adel and Nabila. Assalamualaikum warahmatullahi wabarakatuh, and very good evening. Let me share my screen. You can see my slide now?
Yes, Prof.
Okay. I tweeted the title a little bit because I thought with the current situation that what's going on in the country now, I think it will be more useful to discuss about the current trend and also the issue of what are we doing with regard to managing the COVID-19 as a public health problems in the country. Now, very early in the year, in January, I was invited to give a webinar about COVID in the country and what's the end game. That was the question at that time. At that time, you were in the second wave of the epidemic after a successful, very successful management of the first wave of the country. You know, my response at that time was that to sustain the management of COVID in the country has to be drive by data. It has been evidence-based, and we have to go back to the basic and fundamental in the control of infectious diseases. Right? But what happened now? We can see that after that was our second wave, as compared to our current fourth wave. It's a miniature. At that time, when I showed the first graph, it was so high. But now, compared with what's happening now, it's nothing. But the problem is the principle of lockdown when we have our first MCO during the second phase was actually to buy time to prepare the country. It looks like what happened is afterward we have successfully bring down the number of cases. Somehow we are not prepared to face the resurgence of the infection later. In fact, there was at that point in time I read in the newspaper, in the news, that how confident we were in managing COVID at that time, to the extent that there was even a statement saying that COVID-19 can be curbed without the need for vaccine. That's, unfortunately, what we are facing now is something very disturbing, and we are in the last two weeks we see a resurgence of infection after the and we are not sure whether this actually indicates the coming of the fifth wave with a new variant. Nothing is sure we are at this present moment. Now, the problem with what we are saying is that the number of samples tested continues to decline since the week 21. And the number of cases also followed the same trend. And then we have a surge in number of cases, but the number of samples tested continue to decline. And most of the cases is apparently is coming from the workplace screening, and that could explain why there's a high in sample positivity rate. Now, there's also a sharp increase in the test positivity rate in week 25. In fact, it's highest recorded for 2020, exceeding the 5% level of threshold level for educate testing as recommended by the WHO. And this has been going on for the last 6 consecutive weeks. Meaning, what we are saying here is that we may not have adequately test the population of at risk, and thus we are allowing this infection to continue to spread in the community. Now, coming to SOPs, the factors that contribute towards this transmission is about the space, the density within the space, and the distance, the duration, and the ventilation. This is the basic thing. COVID is airborne. All right. Surface contamination has always been an issue, but until today, there's no clear evidence to suggest that it plays a very important roles in the transmission of disease. Right. But despite that, the emphasis has always been, apart from the wearing of masks and distancing, is on hand hygiene, but very little talk been discussed about ventilation, the role of ventilation, when this is very important when we talk about a closed, confined space. The virus is so small, they get suspended in a very confined place for a longer period of time. And just imagine a meeting room. I mean, somebody before that who are carrying the virus have been talking in the meeting room. When they left the room, the virus can be suspended in there. And somebody unknowingly went into the same room later on, might be exposed to the infection. But I mean, this discussion about the emphasis about the importance of ventilation has not been very prominent in our health education. Now, when we look at the epidemiology of the infection, nothing has changed from what happened last year and what's happening this year in terms of age group, risk group, and in terms of fatality. And the same, I mean, the trend remains the same. But what I'm trying to highlight here is the fact that the risk of dying, the fatality rate started to increase significantly by age of 50, both years, 2020 and 2021. And yet, in our vaccination strategy, we are still focusing for more than 60 years old. I've been driving this. I've been suggesting promoting for the age group to be lowered to 50 for the elderly in this country, bearing in mind that we have a high burden of NCDs in this country. So very high chances that most of those 50 years old are also having comorbid and have a higher risk of developing severe infection. So the importance of actually lowering down the age group for the elderly for vaccination to 50 years old. Now, this spot map was shared by the Ministry of Health recently. But if you look at this spot map, it's very clear that COVID is a very focal, very localized infection. Yeah. The area in Klang Valley, these are the problems facing. It's just a matter of as the transmission got higher and higher. The spot become more dense. But very early on, we know the patterns are very clear that these are the place where we should be focusing our strategies. But unfortunately, we see that we are allowing it to just continue to flare up in the same place. Just another example. You look at the map of Perak. Why I chose Perak, because the only state that have been very consistent in displaying their risk map by MUKIP from early on in the country. In fact, from 2020, it's very clear that some districts have never seen any COVID. Never. It's showing how localized, how focal is this transmission. And we all know the factors that contribute towards this transmission: population density, economic activity, and that kind of thing. So that raised the so when when the government announced the PIK, the Program University COVID Kebangsaan National Vaccination Program, I already very early on suggested that the vaccination program to be based on risk approach rather than going the paces of elderly and so on. Because for example, 3/4 of the cases are in Klang Valley on the daily basis, almost 3/4, if not 50%. So if you can control COVID in Klang Valley, practically you can control COVID in the whole country, because the infection from Klang Valley and also the risk, it's been transported out to other states. So there's always a concern when there's a cross-border movement. So, but we are not seeing that. But I think only recently that the government already started to agree that they're going to move and try to address the more prominent areas. Coming back to the management of COVID as a whole, I strongly feel that we have not been managing COVID based on the fundamental of infectious disease control. There's still issue with regard to early detection, early isolation. In terms of case investigation and contact tracing, I think many of us knows that this has practically not been functioning of late, when many of the cases are not being tracked and contacted and managed appropriately. Now, the last point that I would like to discuss here is about the exit strategy and how we are the government attempt to move on. We are going by phases now, phase 1, 2, 3, and 3. And the government had announced that the indicator, among others, one of it is on the number of cases, 4,000 cases a day for the 7 consecutive days. I have no issue with the use of absolute number, because for public communication, the public can understand better the figure number. But when you translate that into risk in terms of incidence rate, then 4,000 mean 12.5 per 100,000 population. This is the cutoff before you can move to the next phase. And this is very low. If you compare the WHO recommendation for a community transmission level 1, which is less than 20, almost half of what the recommendation is. Such that when you look back at the statistic from SPERA, I compare the existing criteria. The existing criteria is based on absolute number of 40. Anything more than 40 is red. And then the new indicators used by the government is the National Recovery Plan of 12.5% per 100,000, and the WHO stand. If you go by the new National Recovery Plan, almost 90% of the district in Perak are in the red. Whereas if you follow the WHO recommendation, half of them, more than half, are actually is already yellow, already going to the phase 2 and 3. So again, my question is, what is the rationale behind that 12.5 cutoff? Do we have evidence to support such a very stringent criteria in going down? So now coming back to the issue of MCOs, blanket MCO throughout the country, to me, is unjustifiable. I've shown to you that even in Perak, you don't see that every district are having the problems. Why must the green district should be also be put under lockdown and with restricted economic activities and whatnot? And the impact, as you all know, are very serious. Has been reported both in the mainstream media as well as in social media. And the situation is escalating. It's worrying. I mean, if you go by these social media reporting, there's a real issue about mental health in the country, with people dying from suicide and what's not. Last point. What is the basis of these SOPs? The way we are managing those that pass away. You look at the staff wearing full PPE, managing this janazah. The disease is already there. From where is the virus coming from? How can that get transmitted to the staff? That you must wear the full PPE just to carry the body to the burial ground. I don't see the rationale behind this. What are we trying to tell to the public? As you know, because the viral phase is only up to about 10 to 14 days from the peak of the infection. By the time the patient succumb to the infection, they are already beyond the viral phase. It's post-inflammation. There's no more active excretion of the virus. So where are we going to move on from here? I strongly believe that the MCO should be targeted. It cannot be a blanket like this. And we really need to relook at how we are managing COVID-19 transmission in this country with regard to the evidence-based approach in the process. With that, thank you very much for your attention.
Thank you so much, Dato' Lokman. I'm guessing that 15 minutes is not enough if you want to talk about all this COVID and everything, but I mean, you have briefly summarized what I think everybody is thinking before joining this session. So I'm sure there will be a lot of burning questions from the participants. So again, I would like to remind everybody, if you have any questions for Dato' Lokman in particular, you can post your question in the Q&A column at the bottom of your Zoom platform. Then towards the end of the session, after all those 4 speakers have given their talks, then I will read out the questions for Dato' Lokman and also the other speakers to answer to your questions. So with that, thank you again, Dato' Lokman. So before then we move forward to the next speaker. So the next speaker will be Associate Professor Dr. Nur Adina binti Baharudin. She is from the Department of Restorative Dentistry from the Faculty of Dentistry from University Malaya. She will be talking in terms of the dental fraternity. So I think Dato' Lokman have briefly laid the ground for us in terms of the COVID testing. So Prof. Adina will be talking in terms of the dental fraternity. So without further ado, please give a warm welcome to Professor Dr. Adina. Prof.
Thank you, Adam, for the kind introduction. Assalamualaikum and good evening, everyone. Yeah. Thank you for taking time off to attend this sharing session. Right. Okay. As mentioned, my name is Adina. I'm a dentist by training, specializing in periodontics. Yeah. Specialty in dentistry. In layman terms, is the gums or gusi. Yeah. Currently, I'm with the Faculty of Dentistry at the University of Malaya. This is where I work. This is my second home for the last 25 years. This building is located next to the Federal Highway. On the left-hand side, if you're driving towards Kuala Lumpur, opposite the old KWSP building. So this session is about challenges in dental fraternity in relation to COVID-19. Yeah, the menu is on the screen. In March 2020, WHO declares COVID-19 outbreak is a pandemic. At about the same time, Malaysia suspended the routine dental care. And at that point, only emergency care was allowed. Yeah? And they take measures to reduce droplets production. Although at that point in time, there is low number of positive cases reported, it is already anticipated that subsequent wave is coming. And WHO came up with the warning about avoiding places with the 3C. So what they meant is to avoid places that are crowded, close contact settings, and also confined areas. Yeah. They also mentioned that there is a higher risk for COVID-19 in places where these 3Cs overlap. Okay, unfortunately, in dentistry, this 3C fits well among the fraternity. I suppose everybody been to dentist before. During dental treatment, there's no way you can have social distancing. In fact, it has been reported that the face-to-face distance between your patient and between the clinician and the patient is about 0.25 meter. Yeah. The dental surgery is just a small cube, a small clinic, and you may have up to minimum 30 minutes for the session, depending on what is required to be done. Yeah. In the cozy waiting area also does not allow any social distancing. The virus SARS-CoV-2 transmission is commonly by droplet transmission. Yeah? Droplet respiratory that is produced when an infected person coughs, sneezes, or speaks. Yeah? And the direct transmission that you can get is when a person comes in close contact with an infected person. And indirectly, when the virus been transferred to the mucosal membrane by touching the surfaces in vicinity of an infected person. For example, if you touch a trolley which was previously touched by an infected COVID person, you have a high likelihood that you may get in contact with the disease. So the control measures that we have been told or practiced is the wash, wear, and warn. Yeah, it goes to the practicing the hand hygiene. We wear the mask when we come in close contact with people, and we also practice physical distancing and barriers as well. In May 2021, CDC has updated on the mode of transmission for COVID-19 to include inhalation of the virus, meaning that it's airborne transmission. The virus can be transmitted by inhalation of the virus, by inhalation of the aerosol produced by the infected person. And he speaks, when the person speaks or sneezes. Yeah? It is worrying because the aerosol can actually suspend in the air for some time, mainly due to its small size, less than 5 micrometer, and it can travel further up to 4 meters away. So now the risk of COVID-19 infection is higher indoors compared to outdoors, especially in enclosed spaces, especially when you have long exposure and increased exhalation of the infected person. Taken together, now it is not about the hand sanitizer and washing hands anymore, but the airborne transmission is about the air that we breathe in. So the airborne transmission can be reduced by ventilation, as mentioned by Datuk just now. Yeah, by having a good air filtration, reduce the time spent indoors, pay attention to the mask that fits properly on the face, and we use the mask whenever we are indoors, and we provide the higher grade protection for the healthcare workers. People are concerned that the dental aerosol can cause disease transmission, in particular now it's COVID-19. Yeah? People are afraid, and it is understandable that people are afraid. No one wants to get positive now, okay? Positive in a different manner is okay, but to be positive COVID-19 is a no-no. Yeah? And I think dentistry is the procedures that generate aerosols. And the aerosols that are being generated can be contaminated with the saliva and blood, prior to being diffused into the air. Yeah, and it can persist in the confined area, the dental surgery, and these can pose increased risk for the infection. So the concerns are real, since 60% of the infected persons were asymptomatic, and we cannot identify this by routine screening or temperature check. Yeah? So what we're trying to say is, if you were to treat patients with AGP procedures, If you were to treat asymptomatic patients with AGP procedures, this could endanger the health of the dental health practitioners, the clerical, or the other patients. Yeah. So take a look at this article. This article was published by Lancet, where they decode again the dental aerosols. Yeah. In this paper, it mentioned that there are two types of aerosol generating procedures. One is the mechanically produced aerosols, mainly in medicine and dentistry. These are the procedures that produce aerosol. For example, if you cut a tooth for a crown or for a bridge prep, if you do scaling, these are the examples of mechanically produced aerosols. Yeah, the AGP that mechanically produce aerosols. The other type is the one that induce patient to produce aerosols. This is only in medicine. It is not in dentistry. We force the patient to cough, and the cough will fill with high viral infectious dose, and there is a high risk of disease transmission. So from what I deduce from this paper, it is incorrect to assume all AGPs can cause infection, and it should be evidence-based. Yeah? This is another paper that I picked, published by the Journal of Dental Research by a group of Americans recently. So what they did was they conduct these clinical studies. The hypothesis was the microorganisms from the dental AGP, from the dental aerosol generating procedures, are of non-salivary origin. So what they did was they conducted they have three types of AGP: scaling, implant, and restorative work. Yeah, restorative work means you cut a tooth or a crown for a crown or bridge purposes. And this study was conducted in a standard dental setting, to enclosed dental surgery, and they provide proper infection control measures for the nurses and the clinicians. Yeah, they wore the N95 mask. They have the high volume incubator, and they have high ventilations. So they collect samples before and after. So before the study, they collect saliva from the patient and irrigants from the dental or the implant unit. After the procedures, the AGP procedures that I mentioned just now, scaling, implant, and restorative work, they actually collect the condensate from the face shield of the operator, the DSA, the patient's chest, and also an area 6 feet away from the operating site, where they're working. They name it as the environment. Okay, let's take a look at the results. So this chart here is actually what the result, describe the results. Yeah. So they map the result based on 4 areas: the assistant, the operator, patient, and the environment, the 6 feet away site just now. Yeah. The x-axis is actually the AGP procedures, the implant, scaling, and restorative work. Yeah. The y-axis is the percentage source of microbes in aerosol generated by these 3 procedures. And the overall plotting here is actually showing the relative microbial contribution from either the dental irrigants, which is marked by the dark bar here, or from the saliva, which is the stripes, yeah, the black and white stripes there. So their finding is interesting. They found that irrespective of the AGP procedures, yeah, be it from the scaling, implant, or restorative work, almost 80% of the microbes in condensate trace back to dental irrigants. and saliva contributed to a median of 0% of aerosols microbiota. So what we can conclude from this study is that, number one, if you provide proper infection control measures, N95, good ventilation, the HBE, dental treatment does not increase the risk of transmission for COVID-19 disease in the asymptomatic patients. Yeah, and number two, standard infection control practice as described in this study is sufficient to protect the dental health practitioners and the patients. We categorize the dental procedures according to three types. Yeah, we name it as A, which is the aerosol generating procedures that produce aerosols less than 5 micrometer. Group C is the procedures that are unlikely to produce the aerosol, and the B is the in-between, yeah, the one that may produce the aerosol, but the amount depends on the instrument used. Yeah, so for A is the AGP, for B and C we consider as non-AGP, non-aerosol generating procedures. Yeah, and we map to the PPE required for the procedures, and I will explain about this in the next slide. Example of aerosol generating procedures are procedures when you use the ultrasonic scalers for scaling, for example. The high-speed aerodose, when you cut a tooth for crown prep, for fillings, yeah, for implants, that is the considered as AGP. When you use the air polisher, the salt water that they spray in the mouth after scaling, yeah. And when they use the 3-in-1 syringe, yeah, together the air and the water at the same time. The non-AGP, yeah, the B and C are those that are not producing much aerosol, yeah, or no aerosol. For example, the just the normal prophylaxis, you just use the just either air or water for the triplet syringe, impression taking, extraction, endodontic work, yeah, that are all considered as non-AGP procedures. Okay, with COVID-19, the standard or universal PPE before in our daily work is not effective anymore to prevent the spread of SARS-CoV-2 virus, especially when the dental patients have no symptoms of COVID-19, especially when they are not aware that they are infected, or they choose not to conceal their infection. So what we did is, we grouped the PPE requirement again based on the group that I mentioned just now, the category of AGP just now. So group A is the aerosol generating procedures. Group B and C is the one that is unlikely or produce aerosol, but very minimal. Yeah. So basically, A would be just the same like the B, except that for the AGP procedures, they have to wear the head cover. There's a net that they have to wear on the head, to cover the head. They have to use the N95 respirator or equivalent, the fluid resistance gown, and the shoe cover or the boots. Yeah. In terms of our dental facilities, we make sure that there is a safe distance between dental chairs. For AGP procedures, it's about 5 meters away, and for non-AGP, it's about 2 meters away. These are my students working in the clinic, in postgraduate clinic. You can see it's quite spacious. We are fortunate that it can be a bit spacious sometimes. Yeah. And they use the high volume suction, HEPA filter, and we make sure there's good ventilation. Yeah. For polyclinics, yeah, for the undergraduates, we have polyclinics. It's open plans concept where we can have multiple cubicles, up to 35 cubicles in one floor. So it's a bit difficult to make sure that you have the distance, yeah, to ensure the safety distance. Therefore, we built the enclosure. If you can see this closely, there's a plastic that we wrap around the cubicle to confine the area, to make sure the aerosol contained within that particular cube. And you can see the students are doing the prep before they treat their patient. And we make sure the surfaces is easy to clean because the student has to disinfect the cubicle after each patient. We also have procedural mitigation during AGP. We can have among all is the high volume suction, high volume suction, which aim to reduce the splatter droplets or aerosol. May not be suitable for certain procedures. Example, the biopsy, you might just swallow your biopsy away, yeah. And in some patients who have a strong gag reflex, yeah. We can use rubber dam. Rubber dam is the plastic sheet that we put on the face if you do any fillings. But certain restorative work, for example, scaling, is impossible to use rubber dam. Pre-procedural mouthwash also available. Yeah, if you can use that as a mitigation procedure during AGP. So as for conclusion, number one, I can say that COVID-19 stress now included the airborne transmission. Nevertheless, the ways of prevention has not changed. I can say that with proper infection control measures, dental treatment does not increase the risk of COVID-19 in symptomatic patients. Probably we should pay attention to non-clinical areas in dental offices where, sometimes in the clinical setting, we are so worried, we put up the mask and everything properly because we are so worried about the infection. But in areas where we go for our lunch and everything, we forgot about it. We put the mask down, eat, we kind of forget things. So I think perhaps we should pay attention to the non-clinical areas in the dental offices to reduce the risk. Yeah. This is my acknowledgement and references. Yeah. Before I pass to Dr. Wan Nurmila, this is just to share the last family trip I had in Langkawi. Dr. Wan Nurmila is a tourism person. Yeah. So if you notice, the date was just a few days before the lockdown. We managed to go for a mangrove trip along Kilim River. We stopped by the eagle feeding sanctuary. It was very beautiful, and I can't wait for the border to open again so we can enjoy our freedom, back to normal again. With that, thank you.
Thank you so much, Prof. And thank you also for reminding us that we all need a much needed vacations. I just read in a newspaper, I think yesterday, that they're telling us that if you have already 2 vaccinations, that you can go to Langkawi soon. So hopefully we'll be there in Langkawi anytime soon. So with that, I would like to thank again Prof. Dr. Adina for giving us a brief perspective from the dental side of COVID-19, the pandemic from the COVID-19 of the dental fraternity. So without further ado, I'd like to invite our next speaker, Dr. Wan Nurmila Muhammad. She is a senior lecturer from the Faculty of Business and Management in UiTM. She'll be taking us into another perspective of our discussion tonight. She will be talking more in terms of the health tourisms, the prospect and future of this health tourism during this pandemic and maybe after the pandemic. So without further ado, please give a warm welcome to Dr. Wan Nurmila.
Hold on, just my slides. Isabel, could you share my slides, please?
Sure.
No
Give me a moment.
Hi, everybody. I am Dr. Wan Nurmila from the Faculty of Business and Management, UiTM, Cawangan Negeri 9. We have 3 branches actually in Negeri 9, and I am in Seremban, campus Seremban. So, Assalamualaikum and good evening to everybody. So today, tonight actually, I'm just sharing on the medical tourism and what would be the prospect and what we can see on the future of medical tourism. Next. Okay, I guess everybody knows about what is medical tourism. Those medical tourists who come over to Malaysia to get medical treatment, whether it's just a health screening or just having leisure plus medical care, then we call them medical tourists. And based on my experience for the past 10 years on the study, we are actually doing very, very well in medical tourism. Next. Okay, this slide is actually shared with you is about the market size by country from 2016 until projected until 2027. But I'm sure this slide is shared before the pandemic happened. And we are actually on the rise in receiving medical tourists to Malaysia. Next. And we are at the top of the 10 medical tourism countries in the world with various competitors. I would say competitors from Singapore, hospitals in Singapore, hospitals in Thailand, as well as India for Asian region. Next. And this is the revenue, but this one is in 2019. These are the treatment actually that the medical tourists sought after for the medical tourism. So you can see that dental is one of the popular treatment being sought by the medical tourists, as well as cosmetic, orthopedic, fertility, for example, and others. When I did my study in medical tourism last 10 years, actually, surprisingly, the tourists came over to get just the health screening, and they would stay for like 2 weeks or 1 month to have medical, not only as medical treatment, but to actually become the tourist in Malaysia. Next. Okay, these are the major players in the medical tourism market. So you can see that Thailand is very famous, especially for the cosmetic surgery. Apollo Hospital in India, Fortis also in India, and our popular places or hospital in Malaysia is the Prince Court, as well as the KPJ Healthcare. And for your information, Penang is actually giving us, I think it's still giving us almost 70% for the whole medical tourism revenue. So Penang is very popular. So when I did my study, island hospitals, when you went to island hospitals or you go to island hospital last time, you feel that you are in Indonesia, because most of the medical tourists, it's like their home. They come over and then they stayed over, and as well as in Penang Adventist, because Penang Adventist also they have shuttle to receive shuttle the medical tourists to airport, and all the Airbnb homestays are Indonesian people are like paying for rental, because they stay like maybe more than 1 month here in Malaysia. Next. Okay, so you can see here from 2011, okay, 2011 until 2019, we can actually see the growth. There's no, I would not say that there's no coming down. There's is been the rising up of receiving our medical tourists. Next one. Okay, this is just to show you that the comparison between 2003, if you see the picture or the pictorial part on the left side, 2003 until 2019 actually. So projected 2020 will be more than about 2 million. But of course, the pandemic had given a big impact to to global medical tourism. Next. Okay, the revenue, you can see the revenue until 2019. So medical tourism actually is giving a very good revenue to our country. Next. These are the popular, this is a comparison between several countries. So you can see that the cost, okay, the cost that is being sought in Malaysia, you can see that, for example, like heart bypass, we are actually the second cheapest. Okay, the second, I would say cheap, the second lowest as compared to other places, as well as like liposuction. Okay, we are the lowest. Facelift, okay, we are the lowest. So some of the comparison that we can see why medical tourism and why Malaysia is being, the popular country for medical tourism. Next. Okay, the medical tourists that actually fly to Malaysia normally came from China, Vietnam, and Myanmar, but Indonesian was the main medical tourist, the most popular. Reason being that we are, of course, we are the closest, and we have the same language, almost the same language with them. And if through my experience, Penang, Malacca is the popular one, because in Malacca they can have a ferry. They will come by ferry from Batam, and in Penang they will come from Medan. So we have several places that actually cater for all the Indonesian medical tourists. So like Asia is actually helping as well in flying all those medical tourists to our country. So those KL, the popular one will be Prince Court, IJN, and of course KBJ. Okay, so again, if you see here, the treatments sometimes is not very critical, but because we have, normally they come for health screening or dental services and wellness. Okay, the next one. Okay, this is introducing to you the new CEO. Okay, the new CEO of MHTC, Medical Malaysian Healthcare Travel Council. And this pandemic actually based on the CEO, Muhammad Daud, is a wake-up call, because later you can see that our will be medical tourism in Malaysia. Next. Next. So this is what MHTC is doing to actually facilitate in during the pandemic. Okay, so we have they have about 75 hospitals who are being partnered under MHTC in order to actually cater for all the medical tourists. So the private hospital mostly are registered under MHTC to give the services. And MHTC actually is also working closely with other hospitals, okay, like, and then they are also working closely with MOH, the Health Ministry, the National Security Council, as well as the Immigration Department in helping the medical tourists to come to Malaysia and get the best treatment that they can get. Next. Okay, when I get some information from MHTC, people ask whether there are still medical tourists coming over during the pandemic. Yes, we have medical tourists coming over with a very strict safety requirement. They have to like spend a lot actually. They have to have a shuttle flight to, and then when they come over, they have to follow all the SOP requirements. but mostly catering for a very, very critical treatment. So we still have, but in a very limited numbers, as well as following a very strict SOP. Next one. So here you can see that MHTC reportedly projected that a decrease by 75% of total revenue in 2020 because of the closure of the international borders and of course a stricter SOP. Next one. Okay, just to show you the comparison and the prospect, what we can see in the future. Okay, from 2018 until 2021. So next one. Okay, this one was actually captured from NST last year, that our Senior Minister Security Datuk Sri Ismail Sabri Yaakob in a special cabinet meeting had agreed actually to open the international border for the health tourists or medical tourists, but of course to follow a very strict SOP, which you know, giving the medical tourists permission to come and have the treatment here, and hopefully it can, you know, continue to Malaysia can continue to get the medical tourists because it gives a high revenue to the country. Next one. Okay, this it is very small actually, but these are actually the SOP that the medical tourists need to follow from the country, because MHTC actually has a office in Jakarta, in which they can actually query all the medical tourists. I guess because Indonesian medical tourists was the highest number and the most popular. So if they want to get the treatment here, they can still go to the MHTC in Jakarta, and they have to have all the, I would say, procedures to follow so that they can come over to Malaysia. Next. Next one. Okay. So from the CEO of MHTC, we hope that, you know, by opening the borders, but of course we need to still follow the safety and the SOP because what MHTC explained to me, they can bring one companion for those elderly, and they can bring 2 companions for the children. So like parents can actually accompany their children, but only 1 children. But for the elderly, they can bring only 1 companion. Next one. So in my opinion, we still have a future. You can see that the number of medical tourists has not been decreasing, but it's increasing. It's just that the pandemic, you know, like hampered whatever we are having last time. So they will still come, of course, once the you know, like the COVID or the restriction is being lifted up. I would say we will have a good demand in medical tourism. It will continue to increase. Next one. Because during my experience last time, being in the hospitals, you know, meeting all the medical tourists, that would not be their first time to come. They will come and come and come again and again. Sometimes they stay for like 6 months. You know, they have they have their families here. They have you know, friends here. So the revisit intention, of course, will be there. So of course, the prospect will always be there because they need the treatment. They even sell sold their house, their land to come and get the treatment in Malaysia. So it's not surprising to meet people that Malaysia is their second home actually. Okay, next. So,
Dr. Wan, sorry to disturb you. You have 1 minute left.
all right. So this is my actually second last slide. Okay, so this is why Malaysia is still have a strength in healthcare, because our cost, our accessibility, and our quality of service from our medical hospitals. So thank you for giving me the opportunity to share the information on medical tourism. Thank you. Thank you, Isabel.
Thank you so much, Dr. Wan. I'm sure that most of the speakers will say that 15 minutes is not enough. We have a lot to talk about, especially when we talk about the flavor of the year, which is COVID. That's why I think we can see a lot of questions in the Q&A. So just if the speakers can have, you have time to go through the questions and the Q&A, maybe you can prepare some answers for our Q&A sessions to the end of the sessions. So without further ado, I'd like to invite our last speaker of the night, Professor Dr. Mustafa Ali. He is the clinical pharmacologist and also toxicologist, a former professor and deputy dean of Faculty of Medicine in University Malaya, a fellow of Malaysian Academy of Sciences. He is currently the professor and medical director in Mahasa Universities. So Prof. Mustafa will be talking about the enhanced immunity for COVID-19. So can everybody give a warm welcome to Prof. Mustafa? Prof. Mustafa, the floor is yours.
Thank you, Adam. Assalamualaikum warahmatullahi wabarakatuh. And good evening, everybody. Thank you for sharing your time with me tonight. Okay, I don't have slides. I don't think I need slides for tonight, because it's quite a short time. It's only 15 minutes. If 3 hours, I can do some of my slides. Okay. What I'm going to talk tonight is to elaborate a little bit on immunity and also prophylactic measures for COVID-19. Since now we look at the situation, the COVID situation is not as good as we expect, and it's getting worse. Looks like the numbers are getting worse and the MCO is extended. It looks like nothing works. See, everybody looks like there's no light yet at the end of the tunnel. There's no possibility of knowing that COVID will go. So it's very, very difficult to say. Okay, actually what is happening on the immunity side, we have heard about the epidemiology from Dato' Lokman. And now I will elaborate a little bit on what happened to us, what happened to the people themselves. If you can see the data, the rate of death, number of death is increasing, number of people infected is increasing, and at the moment there is nothing that we can do on ourselves to protect, except from taking care of our hygiene, wearing masks and all that. Of course, there is one element that we cannot forget, the vaccination. That process is ongoing. It will go on and on, but the vaccination process doesn't show anything yet. Maybe it's too early, or I don't know. But what I'm trying to discuss is on the what we can do, what human who are living now can do to protect themselves. First thing that we have to remember is that the infection is parallel with our immune system. If our immune system is strong, infection will be much difficult to take place in a strong immune system bodies. So there are a few ways for us to increase our immune system, but there is one aspect that I would like to elaborate in more detail, that is something to do with prophylaxis. Prophylaxis means protection. Currently, there is a worldwide excitement about prophylactic medication. That is what I'm going to describe today is the use of a medication for preventive. They are being talked about throughout the globe, and people have been using it in many parts of the world. That is by using a drug called ivermectin. This is a hot topic right now in many parts of the world, and a lot of people are using it. Some people are buying it through black market, and some people are stealing the drug maybe to get it over to their loved ones, because in Malaysia we cannot get the drug. It's not allowed to be used, and if you possess the drug, you are considered as illegal. But ivermectin actually is one of the most important drug that is used worldwide, and we know if ivermectin is used, most likely COVID will go. That is how strong our belief on ivermectin, and how strong data that is available showing that ivermectin is something that can end COVID in places like our country. There is no issues to say that impossible for ivermectin to help us. There is no issue. There is a complete full set of data to show that ivermectin works, and it is a good prophylactic agent if it can be used. I don't know why we are not using it, because our government still says that there is not enough data. I'm not really agreeable to this claim, because I know there are a lot of data. Maybe they did not look for the right data. I don't know. And a bit of history. This drug actually is an anti-parasite used for animal. It is not an animal drug. I've heard a lot of even KKM doctors saying that don't touch this ivermectin, they are animal drugs. It's shameful. As a doctor, you don't even know what is a drug used for. This drug is an anti-parasite. It can be used for animal. It can also be used for human. And there are many drugs that are used by human and animal. There is no such thing as this is an animal drug. No, for ivermectin is not. They are used in human for the past 30 years. Past 30 years, not 3 years. And this drug is considered as one of the most safest drug in the world. One of the safest drug. So if you have a situation where somebody is dying, somebody really needs critical care, and somebody needs to live, ivermectin is something that is worth looking into to be prescribed for this type of situation, because ivermectin works and it is very, very safe. That means if you prescribe ivermectin, the chances of getting side effect is very low. This is also something that is not right, that is being transmitted into the media by some doctors. They say that ivermectin has got a lot of side effect and don't go close to the ivermectin, which is very, very wrong. The information given to the public is wrong, and this should not be done, because you are confusing the public. If it cannot be used, then it cannot be used. But don't say that ivermectin is very toxic and all that. It is not right. That is not talking the truth about ivermectin. So I would like to clarify this, because we don't want to mislead the public. We have to tell the right thing. Okay. And of course, we know that ivermectin is used for human. It has been used for many, 30 years already. And in billions of people has already been given ivermectin. And the side effect is very, very minimal. And if the dose is given 10 times higher, there is no detrimental effect. That means it is very safe. Okay. What is happening in Malaysia is that ivermectin is not allowed to be used. We cannot use it because of certain reason. We don't have to ask the reason. but it is not an allowable drug to be used here. So the problem right now is that the public is aware of the use of ivermectin, and they are all going everywhere to find black market ivermectin. It is not allowed, but people know it can be used, and they try to get ivermectin through black market, buying from online and all that, which is not good. I don't agree to all this, because a drug is a drug. It should be taken correctly. It should be taken with prescription or with the supervision of a doctor. You cannot go and take drug on your own and use it like that. It is not right. So the situation now is that I would suggest to the government to allow it legally, and allow doctor to prescribe it. At least you can control it, and the public can use it. It is very useful, no doubt about it. So this is something that we can think about. I'm talking as an academic. The government can have a look at this. The data is enough. If you say the data is not enough, that is not very right. You are missing something. It cannot be not enough. However bad the data is, the drug is very safe. And if the need is there, as a doctor, they should be able to consider the weigh the risk and benefit. The risk is very, very low, and the benefit is very high. So that is that status. Okay, now, ivermectin is a drug which has got a lot of mechanism of action, which is positive for COVID purposes. Okay, for COVID-19 purposes. Okay, first thing, ivermectin can reduce the effect of the virus. It prevents the virus from exerting its effect on the body. It is not like antibiotic. It does not kill the virus. No, it doesn't do that. There's a lot of people who've been talking on the media. Some of even the KKM people are talking about that. It's a negative information given to the public, which is very wrong. But this ivermectin is used to reduce the viral load and all that. It prevent the action of the virus. And the second mechanism that is very good is that it can prevent inflammation. So what I'm trying to say is that the first use of ivermectin, the mechanism is very, very suitable for prophylactic, for prevention. So if you have ivermectin, you will not get sick. If you have ivermectin, you will not get COVID. This is the basic concept. Okay, of course, any drug is not working 100%. But if 80% is good enough, you save 80% of the people from getting COVID. See, so this is something that we have to think about it. We cannot just look at it as just like something on the shelf. It is in front of us. We can use it. Why are we not using it? Why? Why are we not using it? It is not toxic. And you have to try. Why? Tell me the reason. I can't understand. So this is something that our government have to look at it. If it is toxic, I understand. Oh, don't use it. Maybe you make it worse. But this thing has no detrimental effect to the extent where it can cause a lot of complication in the patient. It has been studied quite a lot recently, since April 2020. People in Australia, people in many parts of the world. And now there is even a protocol that is given by the specialists, by the experts from many parts of the world, including the United States, which advise the doctors how to use the ivermectin for treatment and for prophylactic. So this is already there, and it is proven safe. It has been proven to work. See, and our what I understand is that our government explained that this is not recommended by WHO. Fine, yes, WHO do not recommend, but that is a guideline. The WHO is a guideline. It's not a rule. We have our own mole, our own people, and we have to take care of our own people. If we think that it is useful, we can always talk to WHO. We are not going against, but it is a guideline that we may not want to follow. there are a lot of WHO guidelines that we don't follow. For example, in monitoring of the safety of water supply, WHO has to comply to the world. Their level of compliance must suit the need of the world. They ask, for example, in the water supply, the poorer countries, they don't have to screen for so many things because they cannot afford. So the level of safety given by WHO is very minimal. We can change it, we can increase it, or we can reduce, because after all, they are guidelines. Why are we so rigid into the WHO advice? We are not saying that they are not doing the right thing, but we have allowance to go. We can adjust plus or minus. So this is something that is banning the ivermectin, making it illegal, is unjustifiable, blatantly unjustifiable, because it is useful. So I would still think that we should rethink about this ivermectin. It cannot be hidden inside the shelf when people know that it can work and people need it. There are people who are dying who may be able to survive if we try it. So this is something very important. This is not just a plea, but you have to look at it seriously. Why are we not using it? Of course, they say there is a clinical trial going on to increase the justification. That clinical trial is used in the third and fourth category. Ivermectin works much, much better in the preventive and the stage 1. So if you are already in stage 3, stage 4, the function of ivermectin, the mechanism of action that is used only on the anti-inflammatory. So that is not really utilizing the power of ivermectin fully. See, so this is something that we have to really look at it. I don't think there is so much of negative things in the ivermectin. Okay, and I would suggest that we should legalize ivermectin, but of course it must be used with supervision. It cannot be allowed just freely to be used. Okay, so this is something that our people can look at, and our government can look at it. And
sorry
of course,
to disturb you, Prof. You have
okay,
1 minute.
Time is over.
No,
Okay,
you have 1 minute.
There's a problem without using slides. I don't know how long I have to go. Okay.
No worries.
The next thing to increase our immune system is to use a lot of good food, supplement like vitamin C, vitamin D, and all that. That help to build our immune system, and it will help us in the certain phase of disease stage of COVID. So the early part of the COVID infection, if our immune system is strong, there is a chance that we can resist it better. So good food, vitamin supplements, and all that are very good. And there are also natural herbs that people are looking at. It's up to them. They can use a lot of good food and good other supplements and all that. So these are some of the advice that we can go, because as it is now, where we are nowhere. To answer the question, the theme for the seminar, we are nowhere. Kesana kesini, nothing. Cirit-berit aja. There's nowhere that we can go. So please understand what we want. See, we need to have something for the people. We need to recover our economy, not just staying looking at left and right for nothing. No. We cannot afford to do this now. Please, this is very important. Okay, thank you.
Thank you so much, Prof. I mean, I'm sure you're very passionate as all of us here tonight. So that's why I think, to be honest, we have around 120 participants so far for tonight, which is quite good for a Saturday night. With that controversial note from Professor Mustafa, I think that's the end of our talk from our speakers, but that's not the end of our webinar tonight. We move towards our Q&A session. So far now, I think we have around 11 questions. Some of it already been answered by our speakers. Before we dive into the questions, I would just like to remind everybody, please stay towards the end because we'll be providing one CPD point for all the participants, and we'll be providing the QR code for you guys to scan, then for you to get the CPD point. There will be also a lucky draw sessions toward the ends, and also please kindly answer the questionnaire provided in the QR code in the screen. I think you can go to Brenda's chat room. There's a QR code there for you to scan and answer the questionnaire. This is for our one of our students here, which is Nabila. All right, then we straight dive into the questionnaire that I will ask according to the sequence here. So the first question will be for Prof. Adina from Mama Amin Muslan. Prof. Adina, why not limit procedures to emergencies and non-aerosol generating since the risk is high? Prof. Adina?
Hi, can I see the question again? Dekat sini. Okay, all right. Thank you for the question, Mama Amin. Why not limit procedures to emergencies and non-aerosol generating procedures since the risk is high? I think I need to clarify here that from what I've gathered, the risk for dental treatment is not high to COVID-19, provided you have taken the necessary measures. As mentioned just now, the proper PPEs, you have the N95, you make sure there's a good ventilation. You know, if you have taken that, the risk for dental treatment is not high. Yeah? And then I think, but probably people get confused because we still wear the PPEs. Yeah, if we say there is no risk from the dental treatment, why you are wearing PPEs when treating patients? The reason being is number one is want to maintain the safety, and the health of the practitioners. Number two is because we assume all patients are potentially infectious. Because as mentioned just now, the percentages of the asymptomatic patients is about 60%. We can't detect by just doing the routine MySejahtera. You know, you check the what they call temperature, you screen. You can't get you may get asymptomatic patients to your clinic, and that's why we have to protect everyone. I hope I answered the question.
Prof, I think there's a follow-up questions also from Mama Amin. He's asking here, with RTK screen, there is a better chances to detect a high-risk patient. So what is your comment on that?
Good job. Yeah, I have answered the question just now.
Oh, is it?
Yeah. Can I see the question?
At the bottom, it's the last, the second last.
Second last.
I think he is just asking about the usage of rapid test kit for screening of high-risk patients, I guess.
The problem is with the RTK kit, yeah, it can give you fast results, but they are not as accurate as the RCT test. What do you call the conventional test lah. So it can give false results, false negative results. Yeah. So that's why I don't think we should screen patients based on RTK and RTK kit.
Just a comment on that.
Sure, Dato'. Go ahead.
It's best to use for symptomatic.
Oh, okay.
When the loads are high, so the sensitivity, because RTK's sensitivity and specificity are very high under that clinical context. But we're talking about your dental patient who are asymptomatic. Otherwise, they shouldn't be in the clinic if they're symptomatic. So a screening for asymptomatic patient to me is not really practical. When a person is asymptomatic, the risk of them transmitting infection is very low, as what Prof. Alina is saying. I think the way forward for in this kind of workplace scenario is very important to address the issues of ventilation. I mean, the design of our clinic at the present moment, not just dental clinic, but any other medical care clinic too, does not pay too much attention on this issue of ventilation in addressing airborne infection. So the way forward for this pandemic, the the entire issues of ventilation, not only in workplace but also in commercial building, will need to have to be addressed. The way that the centralized air conditioning system, the use of UV at the air handling units, and there's also a question of about using HEPA filters and what's not, will need to be discussed and deliberated by the relevant professionals, architects and engineers, in addressing these very, very important issues of indoor air ventilation.
Thanks, Dato'. I think follow up to that answer from you, I think there's one Q&A, one question here from one of the participants, more to a comment lah. Here from Salih. He's saying that here, guidelines are just that, guides, not law or written in stone. In your opinion, what is the reason that Malaysia is hesitant to implement anything during these extraordinary times when it's obvious that the current process is not working? Do you want to answer it, Dato'?
When we are managing disaster, I've answered that one question before that. We are talking about collective responsibilities. It's the government, the whole of government have to address this problem. It's not just Ministry of Health. If the entire system is not working and functioning, it doesn't work. If you ask me my personal opinion, we have issue of leadership in this country, in all sectors, political, health, economic, you name it, with regard to COVID. Otherwise, you won't see the problems of double standard in enforcing compound. You don't see the problems of deputy speaker lying to the public about the durian feast. What do you think we are so stupid, Malaysian, in terms of this kind of thing? I mean, that's how politicians belittling Malaysian as a whole. I think this is bad. We are having a real, let's say, confidence crisis in this country. Okay? And then there must be a strong leadership in managing the issue. It's not just one ministry, it's just not one department. It doesn't work that way. It's a collective responsibility, including us as a rakyat. What the hell are you if you're already on the ping, gelang ping? You still go out and fail to uphold your own social responsibility. That's a crime to me. You're putting people at risk. I mean, so everybody has to be blamed now, not just government. Or everybody, every rakyat in this country also are not, taking seriously what is happening, I guess.
Agree, Dato'. I think we are all in this together lah, to sum it up. Prof. Mustafa, I think there's a lot of questions here on ivermectin. So I'm selecting one that is from Mr. Muhammad Amin Muslan. Prof. Mustafa, any hope of better control of COVID-19 after the adoptions of ivermectin in early treatments COVID-19 in the Philippines and Indonesia?
Yeah, I had a long chat with the person who started ivermectin in Philippines. And it is when before the ivermectin started, a lot of cases and they are very chaotic. And one fine day, one of the politicians got into trouble. So they got COVID and he was treated with ivermectin. And on the spot, a few weeks later, ivermectin was approved. And once they approved, they asked the Philippine pharmacies and pharmaceutical industry to produce ivermectin. And the case dropped. Cases all dropped, and ivermectin is not enough right now in Philippines. They cannot produce enough for the people, and they are in very high demand, and the cases are really under control. So that is not fully, not used by every citizen. Only those who can afford or who can get ivermectin, they use it. And they are also in other countries like India and all that, a lot of data, but unfortunately, some of the real data are not released. They were banned by the websites. So this is something that I was told by a lot of doctors in other countries who say that the data was not there. They cannot publish it. They cannot put it on the tube. So this is something that we have to know.
Well, I would like to comment on this.
Yeah, okay, Dato'.
Controversy is controversy.
Yeah.
You ask me, I have no confidence in the government as yet.
Yeah.
Political data. Look at Peru. It's been introduced much earlier. But look at the number of cases now. They're still going hellbound. I mean, to say that the government is not releasing the data, like for example, India. I mean, there's already a official statement from their medical authorities that I mean they are not promoting for that. And the recently published systemic review on the 26th of June, 4 days ago, doesn't show any benefit between ivermectin and placebo, and ivermectin with resisting treatment strategy. So again, I mean, this is issue of what is the level of evidence that you want to accept.
Betul.
So I think as a government, they have to be responsible. Okay, I mean whether they want to use at what level. So I think it depends. I mean as long until we have the same thing with the hydroxychloroquine.
Yeah,
Chloroquine.
The initiative is so excited about it, but after a global coordinated clinical trial, multi-countries, they found there's no benefit for that. So that's what the WHO is now suggesting, that the well-coordinated clinical trial to review. I mean, if it turns out to be placebo effect, fine, it's just placebo effect. I mean, got to take it. I mean, there's no real danger, serious side effect. I mean, it's up to the MPRA whether they want to register the drug. After all, the drug is already registered in many of the countries. It's just the change in off-label use of the drug. Ivermectin is registered in this country under the lymphatic fluorescence elimination program. But under that program, it's only a single dose once a year. So again, I mean, we are talking about a treatment regimen. What is the basis of that dosing that we are talking about in ivermectin? Those are the kind of evidence still that we have to. I mean, we have to come up with.
But all this evidence, they are already there. But the problem is they were not accepting it. That's all.
So, I mean, there are firstly there are negative findings. So who want to
actually the negative findings were handpicked, cherry-picked, and highlight in the press.
We are talking about an ethical, professional.
Yes, correct.
But I mean, you have to say that it's handpicked. Who are we to say who decide to pick in what? We are not in those.
No. We don't have to decide that. The numbers are there on the publication, and the one that were talked about is only 3. The one that is less
that's what I said. You look at the recent published 26th of June.
There is only one publication, but we have to look at the meta-analysis.
It's a systemic meta-analysis. That paper is a systemic meta-analysis.
But we also have other meta-analysis, which is also showing that it is significant.
So who's to believe now? I mean,
that's why.
That's why I say. I mean, these are the things. I mean, as a professional, you have to go back to the level of evidence you're talking about.
Yeah, we are talking about evidence.
You want to accept the lowest level of evidence. That's fine. I mean, it's not an issue. But let the government be clear about it. So if the government has said, I mean, most countries in Malaysia are also saying that they are doing the clinical trial, let's take it be. Let's get the final consensus agreement on the effects of this thing. All right.
Okay.
I mean, we have agreed.
This is what the government do. But we are talking about.
Next questions.
Okay.
No
carry
worries,
on,
no
carry
worries.
on, carry
I think it's a good platform for us
Carry
to
on.
agree to disagree.
Yeah.
As I said just now, ivermectin is very controversial topic. So there's no right or wrong lah
It
to
is
me.
not controversial. It is made controversial. Ivermectin is not controversial. It's made to be controversial. Okay, carry on, carry on.
Okay,
All right.
we move to the next question, Ada.
Okay, now I lost my chain of thought. Okay, there's one question here for Prof. Adina. Is it good suggestions to let patients coming to OT for general anesthesia to have antiseptic gurgle as the intubation is an AGP? From Tan Tian Chong.
That is the medical question. Okay. I think if you for us, if we're talking, I mean, we dentists also go to OT for general anesthesia, for example, in kids pediatric dentistry. But this is not my specialty. Sorry, I am not comfortable to answer this question.
Sure. No worry, Prof.
Someone else answer.
Then we move to the next questions, or maybe if any of the speaker can answer it, then they can type in the Q&A chat. Yeah. I think most of the question has been answered.
And then there is some in the chat box, not the Q&A.
Oh, okay. Let me go through the chat box. This is from, okay. Dear Prof. Mustafa, as we speak, my friend's driver is dying in Serdang Hospital. Oh dear. He was made to sit on a wheelchair for 24 hours because of lack of beds. And for the last 36 or so, he has been on oxygen mask. His family has been told that he will not be intubated because of lack of facility, because of his age, etc., etc. The doctors in Serdang have to play God as to who lives and who dies. I can provide the details offline. I kid you not. Where's the justice and for fairness of it all? If what you say is true, why is our MOH not allowing COVID positive patients the choice before it's too late? How many more Malaysians must die before our MOH become more prihatin? I think this has been answered by Datuk Dr. Oman and also Prof. Mustafa just now. So for the interest of time, I think I just assume this has been answered. Is that okay, Datuk and Prof?
No. I think the ministry has allowed hospital to request for use of ivermectin under certain circumstances. So now it's up to the clinician. I mean, if they think they want to use as off-label, they are allowed. Apart from the clinical trial, and I've read the announcement that hospital can ask request for information. I think it's something that family members may want to discuss with the thing. But the question is now where to get the supply.
Okay, noted on that. This one question is for Dr. Wan Normila. You said that Malaysia is well positioned for medical tourism on price considerations. We take it that the quality of treatment is comparable and as good as anywhere else. What is your opinion on the current imbroglio on contract doctors going forward? Oh, here's another controversial one. The contract doctors who are not engaged will end up without to undergo specialist training. Several thousand of such doctors will be left out in the cold. In one generation, we will not have enough specialists in our positions. Now I'm afraid to ask to read the questions already.
Yes, so that's why I said this one. I am not comfortable because I know that this is a hot issue currently on the contract medical officer. So I'm not the right person actually to be answering that particular question. I'm so sorry because this it might lead to something else. So I get back maybe to the person later. I need to find the right person to answer this actually, or maybe Datuk can help.
I'm not in the ministry anymore. Not privy to the policy decision. That's not. But this is a reality that we have to face. The fact that, I mean, if you ask my personal opinion is that our healthcare system is already in the brims of not to say collapse, but unsustainable. The cost of healthcare is increasing all years after years, but our current financing mechanism system in the country, the dual system of private and public healthcare system, could not sustain the system anymore. And in fact, we are seeing issues of equity because of this inefficient healthcare system. It's something that we realize. I mean, 90% of the cases are seen by the 10% of doctors in the public healthcare system. But to me, it's an issue of political will to reform. We do not have a strong political will to reform. I think government has been very hesitant about this because we are used to a system that everything's free. And when the government can't afford to support that anymore, as a result, we are having issues of equity. Just look at a simple example of chronic kidney failure requesting for dialysis. Before you go for dialysis, you have to establish the intravenous fistula. Right? And this can only be done in designated surgical unit of hospital. The queue for this procedures is getting 2 months, almost a year, 8 to 9 months before you can get the appointment to do the fistula. But if you have the money, you can go and get it done immediately in the private sector. So there's an issue of about, I mean, the healthcare system entirely. So the problem with medical doctors, permanent medical doctors, is the post. The government simply doesn't have the money properly to pay the salary. It's not a question of the country does not need these people. DG again and again are saying that they are badly understaffed. But the capacity of the government to pay, probably only GPAs knows, not because GPAs control the number of posts and what's not. So there must be some forms of compromise in these things. I mean, something that probably the government may need to relook at the system mechanism, how this can be addressed and managed for all long term. But I believe that the healthcare financing system has to be reformed so that we can have a unified financing system that integrate both the public and the private sector.
Thanks, Dato'. I think we only have 5 questions, but all the question is on ivermectin, which has already been answered just now. So I don't see any questions on the chat box as well. Let me go through it one last time. Dear Dato',
some comments, I think,
yeah, most of it
Amin
is comment. Dato' Dr. Lokman, can I tell the patient family to rush to Serdang Hospital to request administration of ivermectin? This is from, I think, Dr. Raymond, I think. Dr. Lokman, you want to comment on that questions?
I think it's every right of patient to ask anything they want.
I see. Okay. I hope that's answered your question, Dr. Raymond.
Yeah.
And to continue, please alive and sustain. Yeah.
Discuss with the patient. I mean, whatever is the right.
Sure.
Whether the hospital be able to entertain the request also depends on the availability of whatever that's been requested for. I mean, as I said, if the drug is not registered for, where are they going to get a source to find the source of? So I don't know. I mean, I'm not privy to all the policy about government in the Ministry of Health at the present moment. But I don't see any reason why the family members cannot properly discuss with the managing doctors and what's the response. I might be wrong, but it's something that you can. I mean, as a family members, you might want to discuss with the managing doctors.
Sure. Prof. Adina, I think just now you want to answer and something during the conversation between Dr. Lokman and Prof. Mustafa. Anything you want to add on, Dr. Reza?
One question just now, but I couldn't find it anymore.
Oh, okay.
Someone asked me about
AGP, is it?
but probably something that I can share now. Just a comment. People keep asking, why do you practice the routine dental treatment now during the, even if CMCO before our EMCO recently? The reason that worries me is the burden of disease. Yeah, if you look at the National Health Survey, not the Malaysian National Health Morbidity Survey, the burden of periodontal disease, the gum disease, is very, very high. Yeah, and if we don't treat these patients, yeah, when we can treat these patients, because it's been shown that the aerosols does not actually increase the risk of COVID-19. The amount of disease will build up, yeah, and the unnecessary treatment will be necessary one day, right? So they will increase the cost in terms of health to the government at the end. So people ask me why, like in why do you still allow the students to practice? Because for us, part of our teaching is we provide the service. As long as we can make sure that we can provide the necessary precaution based on the infection control. We provide the PPE, the ventilation, the HEPA, and everything to them. I think we should carry on. And I think this is what we are training them to face the real life. They are not, we don't breed them in the lab, and one day we expose them to the real life and they can't cope with it. I think we have to realize that the longer we have the MCO, wherever CMCO, EMCO, it will have not just bad implications to the economy, as well to health. And I'm talking in the context of dental health. Okay, thank you.
Thanks, Prof. I think that should be the end of our Q&A sessions. Then I'll hand over the next sessions to my colleague, Nabila. Nabila?
Okay, I think this is the fun part, but the speakers will not include in this. Lucky draw. Okay, so the name list that will be appear on the screen later will be from your registration form. We take it until 5:30 p.m. today. I'll take your first name and second name. So I'm sorry for any salutation like Doctor or Mr. or Miss. The name will be appeared as you write on the registration form. And please respond in the chat box once your name appears, because you want to know whether you are here or you just register but you're not here. So just respond that I am here. Yeah. Okay, I'm going to share screen now. So sorry, hold on. Share screen.
In the meantime, you guys can also scan the QR code, yeah, for the questionnaire. Thanks.
We have two QR code in this webinar. One is for the questionnaire. I've received about 20 of you already fill out the questionnaire. Thank you so much. That will really help for my dental tourism readiness study. And then there will be another QR code at the end for the CPD points. So we're gonna share that after this lucky draw session. And yeah, feel free to answer the questions. Okay, I'm gonna go to the full screen now. So you guys ready? The first name will be giving you 20 ringgit Grab food voucher. So we will email you by tomorrow for the Grab food voucher. Yeah. Sapuram Rabbit Granas. Are you here? Please respond the chat box. If not, I'll give you 10 seconds. Is there any answer Adam from the chat box?
Not yet. It's okay. I just type the name. Then if they are there, then I think I just type the name in the chat box.
Yeah. If not,
Then
we can proceed, and we did not
Yeah.
take this as the first winner. We're gonna take the next one.
You can proceed to the next one.
Ong Zhang Wong. Are you here? If you're not here, we'll not consider you as a winner.
Yeah. His or she is here. Hong
Okay,
Zhang
so
Wong.
our first winner, Ong Zhang Wong. Congratulations. Remove
We
your
are
name.
taking this down, right? The name, right, Bella?
Yes.
Congrats.
It's okay. It will be recorded in the system as well, so no worries.
Okay. We contributing to the Grab business.
Ip Julie, are you here? Please respond in the chat box.
Not yet. I don't see any reply from Ip Jolin. Then maybe we can go to the next name.
Priya Damodaran.
Priya Damodaran.
Damodaran,
Yeah.
sorry. Please respond in the chat box if you hear.
Yep. Miss
Okay,
Priya
great.
is
We
here.
have our second winner. Congratulations. Can buy food tomorrow.
PKPD.
Winner. Please respond in the chat box if you hear.
The next name is Hui Pin Lim. Are you here? So far, no response in the chat box. Maybe we can go to the next name.
Okay. Wong Zin Nam. Wong Zin Nam. You're our third lucky winner. Please respond in the chat box.
So far, no. I'm not sure where they are. Or they don't want your Grab.
So we have two winners, right, Adam?
Yep.
Okay. Zinat Begum. Are you here? Respond in the chat box.
Zinat Begum, are you here? So no reply, Bella.
What happened to everyone? I'm Lin Chu. Are you here? Please respond in the chat box.
No response.
No response as well. Yusra Zahir, are you here? Miss Yusra?
Yes. She's here.
Yeah, we have
He's here.
our
Third
third,
winner.
right? Third, right? Third or fourth?
Third.
Okay, third. Okay. Thank you.
You're welcome, Yusra. Bit Lian Yi. Bit Lian Yi here. Yep, she's here. Oh, he's
Yay!
here.
So our
Fourth winner. Supatira TV Rasya, are you there?
Please respond in the chat box if you hear.
Supatira TV Rasya. I think no response. I think we can go to the next name, Naila.
Apuram Ravindarna.
This is the second time this name
Oh,
comes up,
I
right?
think I removed, sorry. Fatin Adibah Ghazali.
Miss Fatin Adiba, you here? No response so far.
No? Okay. If you're here, just respond in the chat box, yeah? Catherine.
Catherine Yi? Yep, Catherine Yi is here. So that's our fifth winner. Congrats, Catherine.
Congratulations. We have 5 more winners, yeah, guys.
Kalaivani Subramaniam, you there?
Are you here?
I'm
Please
sorry if I pronounced the name wrong. yes, he's here.
thanks.
Congratulations.
So we have our 6th winner.
There are 4 left. Please hold on. Christopher Daryl Philip.
Yeah.
Mr. Christopher, you're here? I'm sorry if the salutation is also wrong. If you're a doctor, my apologies for not saluting you correctly. There's no response in the chat room, Bella, so I think we can move to the next name.
Iman Nadrah Ahmad. Please
Iman
write.
Nadra, you're here? You with us? So far, no response. Iman Nadra? Yes.
Yay!
Iman Nadra is here. So that's our 7th winner. There's 3 more left. Those who want to view the QR code, I think our colleague Brenda has posted it in the chat room. Yeah, so you can click the QR code in the link. Or you can just scroll down to the name list of the panelists. You can see at the bottom part, the Brenda's QR code. The next name is Hui Pin Lim.
Hui Pin Lim. Are you here? No?
Well, everybody seem more interested to scan the QR code than your than your
Okay lah,
lucky
I bring
draw.
back the 60 ringgit. Oh, Dr. Omar. Your name is here. Are you here?
Dr. Omar Sharif, you're here, Doctor?
Not. No.
Yeah, don't respond in the chat box. Mei Ching Eng. Mei Ching Eng? Is Mei Ching Eng, are you here? Yes. She's here.
Yay!
Congratulations.
We have
That's our winner. So there are two more left. Please bear with us. The link of the cert will be provided after this lucky draw session, just to keep you with us until the end.
you Santam.
You Santam,
Yeah.
you
Are you
here?
here?
So far, no response yet. You Santam. Yes.
Yay!
Here.
We
So
have
that our second last. So this is our last winner.
our last winner. Please be here. Lim To Wang.
Lim To Wang, are you here? No, no answer. So maybe the next name.
Nur Faiza Muhammad Sa'i. Are you here? Please
Nur
be
Faiza
here.
Muhammad Sai. Also no.
Okay, one last one. Ben Lu.
Mr. Ben Liu, are you here? Also no reply in the chat. I think also not
Okay,
here.
we keep one more. If there's nobody responded for this last one, we consider this as a because we already reached 10 o'clock. Okay, one more. Oh, this one already. Sorry. I think she's already here just now, right? Ling Ya Li. Are you here?
Ling Yali, you're here?
Close this session.
Also no.
Okay, so we have 9 lucky draw winner tonight.
So how they
Thank you.
contact you guys? We have their contact address, contact email, right?
Yeah.
Okay.
Our email to them.
So our secretariat will be contacting you guys for you to claim your lucky draw presents. So Bella, if you let me, maybe I can close the sessions. Is it okay? So while I close
I'll
the
share
session,
the
share
QR
the QR code
first.
for the CPD point.
Okay.
So I think we're almost at 10 o'clock already. So we are just right on time to close our session. So before we conclude our session, I would like to again thank all our speaker tonight, Professor Datuk Dr. Lokman, Associate Professor Dr. Nur Adina, Dr. Wan Nomila, and also Prof. Dr. Mustafa Ali for spending your time on a Saturday evening up until 10 o'clock. It is very much appreciated that you are willing enough to share your expertise, to share your knowledge with us tonight. I think most of the participants is really happy to hear from you guys. And I don't think 50 minutes is enough, but I don't think we can go more than 10 o'clock. So with that, again, on behalf of all the committee members, on all the secretariat, and also on behalf of IMU team, we would like to thank you guys again. Very much appreciation. So I think then I pass over to Bella as the chairman of this program to just say a few words before we end the sessions.
Okay.
Bella?
Hey guys, thank you so much for your participation tonight. I already pasted the link for the questionnaire in the chat box, so please feel free to do it anytime, today or tomorrow. And then now we already ended our session. I'm going to give you the QR code for the CPD point. It will appear on the screen. So please scan, put the details there because currently MMA system is down, so they can't provide directly to the CPD point. So we need to email the list to them. So please fill in the questions, the details inside this QR code. Yeah.
Yeah. Just fill in the details, then we'll proceed with the registration to MMA for you. Then we're going to email them all the information, right, Bella?
Yeah, correct.
Oh, okay. I'm using my handphone for this webinar. Okay. Nurjihan Yahya. Okay, we take note of that. Then maybe our secretariat can email you the.
Oh, then I'll paste the link as well. I can paste the link in the chat.
Bella, because some of the participants are using their handphone to join the webinar, so they cannot scan. So maybe we can.
No, I mean the link. I'll paste the link. The link
Okay.
for the CPD point.
Okay.
Okay. So. So this is the QR code you can scan right now.
Anything else, Bella, before we conclude the sessions?
Do you see the screen?
Yep.
Okay. Hold on. We give about 1 minute for them to scan. And I'm gonna paste the link for this CPD point in the chat box also as well. I cannot do it now. So the link is now available on
The chat
box. Okay, please fill in the information there. We will email the information to MMA and we will give you the CPD point to your email. So for any difficulties, you can directly email to us. When you get the registration confirmation, there's my email there. You can feel free to email me anytime. Okay, Adam, I think that's all for tonight. It was really great discussion. We have a really controversial issue as well, but it's really great discussion. And I pass to you for the closing.
Yeah, I think I did my closing just now already. So
okay.
Nothing much to say already. I think it's almost 10. It's 10 o'clock already. Again, thank you so much, Dr. Lokman. Thank you so much, Dr. Adina, Dr. Wan Nomila, Prof. Mustafa, and all the participants tonight. Thank you for spending your time with us tonight. Hope to see you again soon and hope that we are going to end this pandemic soon. And we can go to Langkawi soon. So if anything, there's nothing much to then I just conclude the sessions. Thank you so much. If you have anything, you can email our secretariat for any information. They will be in touch with you through email. Thank you again. Good night, everyone. Stay safe.
Bye.
Nabila, well done.
Everyone, because I need to. Sabel's here and it's leaving. Okay. Thank you, Prof. Thank you so much.
Take care.
Okay, bye.
Okay.
Why is everyone still? Oh, I think they are scanning, right? Yeah, now we can see Brenda's already. The QR code. That one is for the questionnaire, is it?
It's questionnaire, and then the one on the right is the list for the CPD point.